Hello, everybody. We are going to go ahead and begin our next review of our NCLEX prep. I have combined two reviews into this section. We're going to go ahead and start with the leadership portion of the NCLEX exam, followed by the community health portion of the NCLEX exam. Just a quick little disclaimer, I took my NCLEX back in May of 2023. I am utilizing essentially all of the notes I compiled while studying for my exam. In no way am I affiliated with the boards or NCLEX. These are just my personal notes that I took. As always, this is a content review. It is up to you guys to go ahead and practice those questions, and most importantly, review those rationales. When you're studying for boards, aim to do about 100 practice questions per day. Again, this is just going to be a content review. So the content we have laid out for our leadership portion, we're going to start with some delegation, followed by prioritization, a little bit of management concepts, ethics and legalities, and a brief little spiel on QI and IT. We're going to wrap it up with communication before we pop into public health. So let's go ahead and get started. First thing we're going to talk about is delegation. So what is delegation? Delegation is when we transfer the authority to another individual, but we still are remaining accountable. Nurses delegate essentially to our techs if we have an LPN. It helps us not only deliver the best care we can, but it also helps us prioritize. We can't be in 20 different places at once, so we rely on help from others. However, when you are delegating, you still remain accountable. For example, if your tech puts in incorrect vital signs, you at the end of the day are accountable for those incorrect vital signs, even though you did not take it. However, when we are assigning something, we are transferring everything. We're transferring authority, accountability, and responsibility. And this is if I, as a nurse, have 6 patients and we bring in another nurse to come and help us, and now I am assigning her 2 of my patients. Okay, I no longer have any sort of authority, accountability, or responsibility. I've assigned that nurse those 2 patients. And then when we're supervising, we still remain accountable, but we are overseeing. A good example of this would be a charge nurse. Okay. First thing we need to know when we are delegating is our 5 rights of delegation. First being, is it the right person? Is this the best use of an available personnel? If I have 4 techs on the floor and I have 4 nurses on the floor, should I go tell my another nurse, hey, can you go ahead and get some vital signs on room 4? I can't do that right now. Well, actually, a tech would be the best person to do that. So my nurse can do other things that are more, at the end of the day, within her scope of practice. Not that vital signs aren't within her scope of practice, but is that really the best use of available personnel? Okay. Next being the right task. Is it within their scope of practice? This is kind of what I mean by right person. For example, a nurse can pass medications, a nurse can assess a patient. So if I am trying to prioritize and delegate, I want my nurse to do the tasks that nobody else can. In the same way, while a tech or unlicensed assistive personnel, they can't go pass medications, they can't go perform assessments, but they can do vital signs, they can bathe my patient. So I'm going to make sure that the task I'm delegating is the right task for that person. The right circumstance. Is the situation stable, and are there appropriate resources? I have to make sure that if I delegate, I'm doing so safely. I also have to make sure we have the right direction and right communication. If I'm telling my tech to take vital signs, she's going to take the vital signs, but I need to tell her, take the vital signs in room 4 and report back to me. Okay. Or, hey, I know you're taking my vital signs for my patients. Let me know if the blood pressure is less than 110 in any of the rooms and report back to me. So I'm giving the right direction and the right communication. And then finally, right supervision and right evaluation. Was it effective? Did it work? Okay, beautiful. So what can we and what can't we do? So in the hospital, you have your registered nurses and you also have your LPNs, your licensed practical nurses. It's very important to know pretty much what we can and cannot do. So registered nurse, essentially, we can do everything nursing based. We can use the nursing process, we can use judgment, we can assess. It's very important that a RN is the first to do anything, the first to ambulate a patient post-op, the first to provide first education, the first to initiate tube feeds, the first to start IV fluids, IV medications. We also can perform assessments and determine, was our intervention effective, or do I need to make adjustments? We also do initial workups, okay? It also should be the registered nurse that communicates with other departments. For example, taking report from a post-cardiac cath patient. If you're getting report from cath lab nurse, it should be a RN that's receiving the report and also giving the report. A registered nurse should also be the one to take care of our unstable patients, okay? And we'll review what makes a patient stable versus what makes a patient unstable. Nurses can also give any and all medications, including IV medications. An LPN, on the other hand, while they can reinforce education, they can't initiate and they can't be the first person to teach them that education. LPNs can also give oral medications, and they can perform sterile procedures such as trach care, inserting a Foley, things like that. However, they cannot deal with central lines. Even though central lines are a sterile procedure, they still cannot be working with those. They cannot initiate tube feeds, but they can keep a patient that's already been started on a tube feed. Okay. They can also do select assessments like auscultation, because you're not really interpreting those results. It's essentially just very select assessments in a way that's monitoring lung sounds. Okay. They cannot determine intervention effectiveness, and they should be taking care of stable patients, okay? In the event that you are on a floor that does not have a CNA or a tech, that's a unlicensed assistive personnel, pretty much we're going to delegate all the tasks of a tech to an LPN because it is within scope of practice, okay? Also, at the end of the day, a registered nurse can do anything that an LPN can do and anything that a UAP can do. However, we do need to delegate appropriately when we can. So these are our techs, our unlicensed assistive personnel. Essentially, they assist us with our activities of daily living. They help us with putting on SCEs for patients, bathing, cleaning, grooming, feeding, etc. They also help us with checking vitals and blood sugars. However, it's also up to the nurse to provide that right communication. We have to tell the tech what to report to us. They're not going to be able to say, I just took this blood pressure and it's 80/40. Should I or should I not tell the nurse? It's up to the nurse to say, hey, report blood pressure less than X, Y, and Z to me. Or let's say I have an unstable patient, I'm going to tell the tech, go take the vitals in room 49 and immediately report back to me, okay? UAPs cannot do any sort of teaching, assessments, or monitoring. They can feed and give nutrition to stable patients. However, they should not be the ones that are giving kind of that first feed to a stroke patient. We know stroke patients have a lot of dysphagia. It's not going to be safe for them because they just really don't know those things, and that's okay. They are unlicensed. All right. They can also give over-the-counter topical creams such as barrier creams, but they cannot be giving like medication creams. They can also empty drains, measure the amounts, and record. They can record Foley output. They can empty a JP drain and record the amount that was in, okay? They chart what they did, meaning UAP charts emptied Foley. They can't document patient tolerated well or patient experienced pain during this. They simply chart what they did. Okay. In the event that you delegate something to a UAP and they tell you no, it's up to you to further investigate. Why did they tell me no? Are they nervous because they've never done it before? Or is it something that they don't know is within their scope of practice? Okay, always assess the reason why. A little bit of a side note for new graduate nurses that are just starting out, they should be taking care of stable patients with chronic conditions. When you have a float nurse, okay, this doesn't necessarily apply to a med-surg nurse floating to med-surg. This would be like a pediatric nurse floating to adult med-surg, okay? While we all get the same education through nursing school and we all have to take those regular courses in order to get your nursing license, they haven't had a lot of experience with adults. So we should not be giving a pediatric nurse who floated to an adult floor adult cases such as alcohol withdrawal or COPD. However, you can give a float nurse from a pediatric floor someone with sickle cell crisis because that's also common in pediatrics, okay? We also shouldn't be giving float nurses discharges or pre-ops. When it comes to delegating to family can help out with us. However, they should never be delegated anything safety-wise. For example, if you have a patient that requires one-to-one sitter, you can't just say, oh, well, family is at bedside. They still need that one-to-one sitter. Also, if you have a mom that is with her baby and the baby needs to be in the crib with all the rails up, it's okay that mom holds baby, but we have to be there when mom puts the baby back into the crib so that we can ensure that all the side rails are up. Even if mom says, oh, it's fine, I'll get the side rails, we need to see those safety rails come up, okay? When giving instructions or education to a family member, it's very, very important that we document education was provided. Up next, we have prioritization. Couple good rules of thumb. We always prioritize systemic over local, acute over chronic, actual problems versus potential problems. When in doubt, use Maslow's hierarchy of needs. We also prioritize emergency findings over expected findings. Always, always, always do your ABCs, airway, breathing, circulation. We prioritize the vital organs, brain, lungs, and heart. Okay, brain is the top priority, followed by the lungs, followed by the heart, okay? So let's talk about stable versus unstable. So your stable patients will be chronic, patients with chronic illnesses, greater than 12 hours post-op. They have elevated BUN, creatinine, sodium, hematocrit. Those are typically stable findings, okay? Typical findings associated with a disease, okay? You have someone with COPD. A typical finding is their O2 sats to be probably around 88 to 90. That's a typical finding. Or patients that are ready and cleared for discharge. Unstable patients, these are our patients that are less than 12 hours post-op or patients that have received anesthesia. Elevated INRs are unstable patients, as well as patients with hyperkalemia. Any sort of hypoxia or hypoglycemia is also unstable. If they've been admitted for less than a day, they are unstable. Some other findings that might make a patient unstable are increased white blood cell count or temperature, patients with a newly diagnosed disease or new admits, anyone with a hemorrhage, and as always, anyone that is pulseless, breathless in VFib or asystole. And I've just compiled a list of some examples of priority findings that require priority treatment. Any sort of fever with neutropenia is a priority. Basically, your immunocompromised patients presenting with a fever, any altered level of consciousness or low Glasgow coma scale, really anything with symptoms. You have a patient that's hypertensive but asymptomatic, it's not necessarily a priority, but if they begin to show symptoms such as blurry vision, dizziness, headache, they are now priority. Any breathing issues, overdose, new onset agitation or confusion, low blood sugar, really anything with involving the PICC line and critical lab values. Okay. Now we get to move into management. There's different styles of leadership. We've got our authoritative, democratic, laissez-faire. Authoritative leadership style, essentially they make quick decisions and they have others follow. It's very important to know, when are these different styles beneficial? An authoritative leader is very, very helpful when running a code. Okay, quick decisions, do this, push epi, start compressions. There's no kind of room for when a patient's coding. Like if you had a democratic leader that was, what do you guys think we should do right now? Do we think that's a good idea? Yes or no? While that might be good for like a quality improvement plan, not necessarily the best for emergency situations. Same thing with our laissez-faire. They take a back seat, let others work it out. Again, not the best for emergency situations, but might be good for interdisciplinary conflict, letting them work it out. Okay. It's very important that our leaders are both transformational leaders and transactional leaders. So what's the difference between leadership and management? So with leadership, these essentially are role models, motivators. They help advocate, they give knowledge and delegation, whereas our management, these people are more involved in establishing goals, quality improvement. They can help with budget and lunch assignments. But really, they do a lot of planning and organizing. Okay. Up next, we have conflict. There's different ways people respond to conflict, such as avoiding, cooperating, compromising, or competing. Okay, so just go ahead and review those brief examples. Some tips for dealing with conflict. If there's any sort of bullying in the workplace, first thing we want to do is we want to observe the situation. We want to document it, and we really want to report it to a supervisor. Many places have a non-tolerance for bullying protocol. It's also important when dealing with conflict to use I statements and be assertive. We don't want to put blame on others by using you statements. It's just that I see, you make me feel, things like that. We want to use I statements. This is something I observed, I feel, things like that. So it's also important, when do we intervene? Okay, there's a couple different things I want you guys to understand for intervening. There's two options. We're either going to confront or we're going to take over care. Okay, we can also tell our supervisor, but we need to know, when are we going to confront something versus taking over care? So confronting is, I've noticed something that isn't really immediate harm, but I need to confront them so that we can prevent harm. This would be a surgeon breaking sterile field or a nurse breaking sterile field. We're going to confront, hey, stop, you broke sterile field, let's redo it. When do we take over instead of just confronting? We're going to take over care if something is illegal or harmful. So if I notice that my tech is doing perineal care without gloves, that is harmful for not only the patient, but also my tech. That patient might have some sort of disease that is transmissible. So I need to stop and take over care right now. I need to tell my tech, stop, go wash your hands, do X, Y, and Z. I will do this. Okay. If something is illegal and nobody is in immediate harm, this would be, you notice a nurse is stealing narcotics. First thing we do is we tell our supervisor. Okay. However, if there's a situation in which someone is in harm, such as a nurse who's inebriated about to pass medications, that's when we're going to take over care immediately, and then we report it to the supervisor. Okay. Little caveat, if a patient is having sex, we give them privacy. We don't try to stop them. Stopping them could cause more harm and damage than good. Okay. Couple different concepts for leadership and management. It's up to management to really figure out placement, especially when you've got those rooms that have 2 beds. They need to figure out, okay, who can we place together versus who can we not? So We are going to separate patients with skin or respiratory infections from susceptible patients. If we have patients with open cuts, open wounds, like from surgery, we're not going to put them in a room with someone that has a disease that is spread through droplets, or someone with another communicable spit infection. Okay. We avoid placing two patients with susceptibility to infections in the same room, meaning two immunocompromised patients. They should have their own room. Okay. For radiation exposures, we assess time and different distance. Okay. If there's a radiation exposure, we don't want to immediately go run to those closest. That can cause a lot of harm to you. So we're going to work backwards. We're going to save those furthest away first. Okay. For case management, nurse management, things like that, it's really important that the nurses coordinate care from admission to discharge and help initiate those referrals. If you have a patient that's about to be discharged on medications, but their medications aren't ready, we're going to delay the discharge and contact case management. It's very important to get social work involved. They can help. Okay. Up next, we have ethics and legalities. It's important we always respect patient autonomy. The patient does have the right to make their own decisions. We also make sure that we always have the patient's best interests in heart, and we're always being confidential. Also, fidelity is another one, keeping one's promise. If you say, hey, your patient has a request to switch her oral pain medications to liquid form, and I say, don't worry, I'll take care of it, and next med pass goes around and I still have the oral medications, not really practicing fidelity. As always, we want to do no harm, and we always must report abuse. Okay. The nurse's role, we have many roles in healthcare, but we are absolutely the advocate, the caregiver, the educator, and the manager. Couple more concepts, advanced directives, living will. On admission, we should be asking patients, do you have any advanced directives or living will? And if so, can you provide a copy? Okay. What is a living will? So a living will states what type of treatment they would want for end of life treatment. So in the event that they are at end of life and they're unable to make decisions for themselves, earlier in life, they can say, this is what I would or would not want. If I was unable to, a very common one is patients don't want PEG tubes. So in the event I am unable to swallow, I don't want a PEG tube. That's okay. We have a lot of patients that can have a stroke, and that leaves them essentially brain dead and they're not able to eat anymore. And a living will, it would state that they would not wish to have a PEG tube. Okay. Up next, we have power of attorney. So this is basically a form that says, in the event I am unable to make decisions for myself, who will make those decisions for me? And ideally, they would want to appoint someone that would help follow their living will and their wishes. Okay. If a patient can make decisions for themselves and they are at end of life and they are in sound mind and able to make those decisions, they don't need their power of attorney present. The patient is under 18, we will always perform life-saving interventions, even if the patient say no, or even if the parents say no. And then finally, advanced directives. So this states what the patient would want and healthcare decisions they would make if they cannot make those decisions for themselves. Alrighty, up next we have tort laws. So for tort laws, we have an unintentional tort. Unintentional torts are negligence and malpractice. A quasi-tort, this is defamation of character and breaking confidentiality. And then an intentional sort would be assault. Assault could be threats, verbal threats. If you don't take this medication, I'm going to strap you down to the bed. And then battery would be kind of touching without consent, pushing meds in an IV without consent, things like that. So what is the nurse's role and responsibility? We always intervene and take over care if safety is at risk. It's also up to the nurse to verify and witness informed consent, and also make sure the patient is able to provide informed consent, meaning we have to make sure the patient's alert and oriented and they have the capacity to make decisions. You just gave a patient a bunch of narcotics and they're out of it, they're not able to make those decisions. So we also have to make sure, is it appropriate for informed consent right now. We also can assist with ethical dilemmas surrounding end-of-life care. Avoid saying, well, if it were my mother, I would do this. Instead, we ask the patient or the family members the advantages and disadvantages of both options, okay? We always have to make sure we're practicing within our scope. That's specific for the Good Samaritan law. So with me being a CLS nurse, it's also a BLS nurse, basic life support. Someone passes out in Publix and loses their pulse. I can start CPR, I can put an AED on them, but I can't intubate in the field, okay? That's not within my scope of practice. Same thing for the hospital. You must always report suspected drug or alcohol abuse of a coworker. You must tell your supervisor, okay? What do we need to report to the National Council State Board of Nursing? Giving medications without a prescription, false documentation, stealing medication, and abandonment. In the event a family member does get hurt on your floor, you cannot care for them. You must take them to the ED and they must be admitted. Okay. Speaking of the ED, we talked a little bit about HIPAA earlier. It is okay to call a patient by their name in the ED, specifically the waiting room. Okay. So up next we have documenting in the electronic health record. We have to make sure everything we document is thorough and factual. We do not document incident occurrence reports. This is falls, lab's not done. If a fight broke out, we don't document that, okay? We also never document will continue to monitor. And then a brief word about ethics. We have what's called our mature minors. These are patients that are age 14 to 18. They can do a couple things without parents' consent. Those things include donating blood, getting STI checks, and receiving family planning, receiving any sort of drug and alcohol abuse care or mental health care. We also have our sentinel events. These are our never events, essentially things we never want to happen, such as unanticipated death, amputation of the wrong leg. We also have our near miss events that do not cause harm, but we still need to report near miss to supervisor so that we can figure out some education, okay? We also have our Baker Acts. So what patients can't leave AMA against medical advice? Any sort of long-term pediatric illness. If a patient is disoriented, maybe you've got your patients with Alzheimer's dementia that want to leave, but they are not oriented ×4. They don't know what year it is. Patients that are on heavy sedating medications, they're not in sound mind to say, I want to leave against medical advice. Also, Baker Acts or patients that are at risk for harm to themselves or others, they can't leave against AMA. Even if you have an adult Baker Act patient and they have their medical proxy, the medical proxy can't sign them out against AMA, okay? Alrighty, and finally, we've got some communication. So we always use the acronym SBAR. We want to talk about the situation, a brief background, followed by our assessment and recommendation. So situation. Hi, this is Tiffany on floor 3A. I'm with Mr. Jones. And Mr. Jones is experiencing some shortness of breath. That would be like a good situation. Brief little what's going on. Background, patient came in on the 9th with a DVT of the left leg. My assessment findings, patient's blood pressures X, Y, and Z. Patient is having friction rub upon auscultation. Patient's O2 sats are 88 and he is on 12-liter non-rebreather mask. The patient is anxious, diaphoretic, sweaty, clammy skin. Recommendation, I believe the patient has thrown a pulmonary embolism, and I think the patient needs to be started on anticoagulation therapy, or it's perfectly okay to say, I'm not sure what the patient needs. Can you come and assess the patient? Or do we need to call a rapid response on the patient? Okay. Handoff. It is very important to do nurse handoff. We should be doing bedside shift report. So what are our do's and don'ts? notes. In handoff, we do want to give the patient's name, age, what their problem is, and what their diagnosis is. We also can give baseline vitals and respiratory status. So perfectly okay to say vital signs have been within normal limit. By respiratory status, I mean, is the patient on oxygen? If so, what? Are they on 2-liter nasal cannula, 10-liter non-rebreather? Are they on heated high flow, 30 to 40? What are they on? Okay. We also discuss with the treatment plans, goals of care and effectiveness. This is Mr. Jones. The plan of care for him is to be evaluated by speech language pathology for his new stroke, also to begin rehab, things like that. We also communicate the scheduled time procedures. Mr. Jones will be going down for cardiac cath at 9 a.m. Or Mr. Jones came back from cardiac cath at 5 p.m. So he will be on his 6-hour bed rest that will end at 11 p.m. Okay, we communicate scheduled time procedures. Communicate the priorities and the to-do list. Okay, what should we not do? We're not going to go over expected findings. You don't need to go over, these were his labs. Potassium was 3.8. Sodium was 130. Anything that's expected or normal, we're not going to report. We also avoid using our personal opinion. Alrighty, last but not least for our leadership portion, we've got a brief little information technology. Just always make sure we're logging off our computers. We're not just turning the screen off, we're fully logging them off. We also should make sure everything is password protected and we're not sharing our password with anyone. Above all, follow HIPAA and use reliable websites. It's up to leadership management to help with quality improvement. The process includes developing standards, identifying the issue, choosing data, again, from a reliable source and analyzing it, help identify the root cause and solutions, and then implementing those solutions. Okay. Awesome. Alrighty, so that was it for leadership. We're now going to head into our community health, very, very brief portion of your NCLEX exam, okay? A lot of it kind of goes hand in hand with our fundamentals, for example, infection prevention, things like that. So we are going to specifically talk about the nurse's role in community health, followed by a few geriatric vaccines, and the majority of community health is disaster planning, okay? So what is the nurse's role in community health? The nurse's role is to assess community needs, resources available, costs, and funding. We also help make referrals to mental health resources, things such as Meals on Wheels, support groups, etc. What is an example of community health nurse? Well, we've got our home health nurse, school nurse, and hospice nurses. It's also very important that they are advocates for vulnerable groups and provide culturally competent care. Always utilize an interpreter when necessary. Okay. Alrighty. So you might recognize this from our fundamentals review, but we've got our airborne droplet contact and protective precautions. This is also why I think personally community health goes hand in hand with leadership, because a portion of leadership is trying to assign patients to the same room. What patients can go in the same room, what patients need to be in a room by themselves. For our airborne precautions, these patients should be in a private room with negative airflow. For the nurse, they must wear an N95. And if the patient is being transported to surgery or somewhere else in the hospital, patient must wear a surgical mask. Examples of airborne precautions are varicella, shingles, measles, and tuberculosis. Patients with droplet precautions must wear a gown and gloves and need to wear a surgical mask within 3 feet of the patient. They can be placed in the same room with someone as the same infection. For example, we can place 2 patients with RSV in the same room together. However, we cannot place a patient with rubella and RSV in the same room, even though they are both droplet precautions, but not the same infection, okay? Examples include meningococcal, RSV, rubella, and meningitis. Contact precautions include gown and gloves, and everything in the room will need to have its own equipment, such as its own blood pressure cuff, its own stethoscope, things like that. Okay. We also cover wounds when moving the patient. Examples include C. diff, HSV, MRSA, rotavirus, dysentery, and VRE. And finally, our protective environment. This focuses on protecting our patients from infections. These are going to be your immunocompromised patients, such as patients with HIV or AIDS, patients that are chemotherapy, cancer patients, or anyone that's immunosuppressed, like our transplant patients, okay? We're going to utilize standard precautions and keep as sterile as possible. They shouldn't be taking any fruit, any raw vegetables, uncooked foods, things like that. Remove flowers from the room, no freestanding water. Beautiful. Public health nurses also focus on preventing illness. Our primary prevention is preventing illness. This includes education, vaccines, proper nutrition and fitness. Secondary prevention focuses on screening. This is going to be advocating for annual physical and dental checkups, colorectal exams, teaching women to get a pap smear every 3 years. Finally, tertiary prevention really focuses on preventing long-term complications. It's going to be cardiac rehab, things like that. So what are our geriatric vaccines? Very helpful in primary prevention. It's up to the nurse to educate that when we have our older adults, even though they got these vaccines when they were younger and when they were children, we need to re-up them. It's going to include the varicella and varicella zoster vaccine, essentially preventing shingles, our pneumococcal vaccine, and our hepatitis B vaccine. And up next, we have our disaster planning. So what are some types of disasters a nurse or a public health nurse might encounter? Well, we have our internal versus external disasters. So an internal disaster would come from within the facility. For example, you had a fire at your hospital. An external disaster comes from external forces. This would be a terrorist attack or a natural disaster. The goal of disaster planning is to provide disaster management education to the public. This is essentially providing teaching on how they can make their own disaster kits. Fire safety plans for a household. If you've got a house with children, okay, if there's a fire in the house, how are we going to get out? Where are we going to meet? Examples of bioterrorism, you have categories A, B, and C. Essentially, category A is our highest priority, highest risk. These are spread very quickly and they have the highest mortality. This would include anthrax, smallpox, Ebola, and the plague. Category B is moderate morbidity and low mortality. So while this can cause some uncomfortable symptoms, there's a relatively low mortality rate. Like E. coli, West Nile virus, it's going to cause a lot of, GI upset, diarrhea, but fortunately has a low mortality rate. And then finally, category C, this is low priority. This is our influenza, tuberculosis, and rabies. Essentially with our category C's, a lot of it is treatable. Okay, so what is the disaster response? First thing we must do is declare the disaster. Once a disaster has been declared, I want you to think this is no longer in the hospital nursing ABCs. We have a little bit of a switch. This does not apply for a patient that is in the hospital. This is essentially only for disaster response, okay? Mass casualty events. So we declared the disaster, we're coordinating with organizations for help, we're figuring out what we need for hazmat PPE, and then finally we are starting to triage the patient. This is not hospital triage. This is not a patient that's come to the ED. How are we triaging them? We're treating everybody. But in the event that we have declared a disaster, we must triage. We've arrived on scene, okay? We're gonna start tagging people. Are they black tags, red tags, yellow tags, or green tags? So with our black tags, death is expected, okay? These patients may require too many resources to survive. Therefore, we're not going to provide care. Again, this is not traditional hospital. Patient comes to the ED from EMS and death is expected. We're still providing care. But again, disaster response, this is different. So examples of someone that you would black tag, this is massive head trauma. You've got odd pupils. They're not reactive. One is blown. Patient's got agonal breathing, cardiac arrest. Okay, these are not who we're going to provide care to. A lot of people get confused. Oh, patient in cardiac arrest, we can do CPR. In these events, we don't know how long they've been down. They're going to require at least 2 to 3 people to perform CPR. That's taking away resources. We need to figure out who is emergent. Okay, obviously in the hospital, patient comes from EMS and they're in cardiac arrest, we're going to act. But again, this is disaster response. This is different. So who are we going to prioritize care for? These are going to be our red tags, our emergent patients. These patients require immediate treatment and should be treated first. Example would be airway obstruction, any altered level of consciousness, or excessive bleeding. Urgent patients require treatment within 30 minutes to 2 hours, and they are our second priority. Patients got an open fracture. If they're hemodynamically stable, not hypotensive, not bleeding out, we want to yellow tag them, meaning they're not our highest priority, but we want to make sure that they still do receive care. Then finally, we have our green tags. These are our walking wounded. This is going to be minor cuts and scrapes. And we end with our recovery stage for disaster management. This starts when the stand down orders are placed, and essentially our focus has shifted from treating to emotional health and coping. It's very important that we debrief as a team. Alrighty, everyone, thank you so much for coming to our leadership and public health review. As always, if you need anything, please go ahead and let me know. I hope this was very helpful for you guys. And as always, happy studying.